And it is such a pleasure to be here today in this beautiful community of individuals across the world to really engage in a fun discussion today, to really think about how does integrated care and engagement fit together. We know both of these things are really critical, but what do they mean when they come together, and why should they come together? And that's what we're going to discuss today. So what I'm going to do, I'm going to introduce the panel. I'm going to provide some background just for some context setting. And then we're going to move into a fireside chat panel. But so pleased to present such a stellar group of individuals to help us kick off the discussion today. So we have Nakia Leefoon. Dr. Leefoon is the inaugural Health Equity Lead at the Institute for Better Health at Trillium Health Partners. She received her PhD in Social and Behavioral Health Sciences at the Dalla Lana School of Public Health at the University of Toronto. She has over 10 years of experience conducting qualitative and mixed methods research with racialized communities. And she sat on the board of directors for the Black Health Alliance, where she was the vice president from 2016 to 2018. Professor Robin Miller is an applied academic and with an international reputation in relation to integration, leadership, and implementation within health and social care. He's the joint editor-in-chief of the International Journal of Integrated Care and a senior fellow of the School for Social Care Research. He has an interest in community-led, asset-based approaches to integrated care, development of collaborative leadership in senior and practice roles, and embedding co-production within the design and delivery of transformation programs. Helen Lightfoot is a senior practice consultant with Connecting People and Community for Living Well, which is an Alberta Health Services initiative. Her background is in social work and community engagement in rural and urban settings. She was a frontline home care case manager for 20 years and subsequently held management and practice lead positions. Throughout her career, she recognized the important role community plays in supporting people's well-being, and her preferred pronouns are she, her. Sandra Holdsworth spent 30 plus years in the banking industry. She was an event coordinator at Canadian Blood Services and worked for Hospice Muskoka as their fundraising and events coordinator. Her healthcare journey includes receiving a liver transplant in the late 90s after several years of going undiagnosed with a rare liver disease and Crohn's disease. After years of treatment, she required a permanent ostomy in 2012, and she now has chronic kidney disease due to long-term immunosuppression medications. She was a volunteer with Trillium Gift of Life Network and awarded the Community Champion Award in 2015. She served as provincial director of the Canadian Transplant Association for 8 years and is currently an active patient partner with the Organ Donation Transplant Collaboration headed by Health Canada, a longtime advisor for the Muskoka and Area Ontario Health Team and formerly with Health Quality Ontario. And she's been on the Ontario Minister Patient and Family Advisory Council since 2021. And she's actively involved with the Ontario Strategy for Patient-Oriented Research. And it goes on and on and on. Such a pleasure to be here to facilitate a discussion with all of these amazing individuals and all of you here today. So to kick things off, Robin, I'm gonna start with you. And I wonder, in the work you've done and the ideas you've generated over all the years of work that you've done, in your view, how does patient, community, caregiver engagement and integrated care fit together? And can you sort of speak to some examples tangibly so we can understand what that means from your perspective?
Yeah, thanks, Kerry. Very happy to go first. So what I thought I'd do is reflect on a project that we've just completed over the past 12 months as part of a centre called Improving Adult Care Together Centre, which is a UK-wide centre, which is not about generating more research, but trying to understand how we can use evidence in order to inform the delivery and planning of social care and social care in collaboration with healthcare. And in the centre, we have a broad view of evidence. So yes, we do try to look at research studies that have been done, but we also looked at lived experience and also practice wisdom, because we see those as being equal contributions as evidence. And the first project that we did was in Mid and East Antrim, which people may know is in Northern Ireland, just outside of Belfast. And it's a rural area, a number of small towns. And the reason we went there was they had a long-standing project there run by Mid and East Antrim Age Well Partnership, which I think is a great example of community-based integrated care in action. And what the project does is it connects together social workers, general practitioners, and pharmacists with community resources. And MIAP's project workers bring together locality hubs of those three professionals. They then will respond to older people who are seen to be isolated and generally struggling with life, and go and see them and have a very open conversation what matters to that older person in the family. And then we'll connect up the older person and their family with a range of community resources. And what's different about this project rather than traditional social prescribing is, first of all, it very much emphasises the interprofessional aspect, that the locality hubs an opportunity for those different disciplines to come together to talk about the needs of individual older people, but also the community. The second thing is that it takes a real community development approach. So it works with the different community-led organisations to talk about what they see as the emerging needs of older people, and to make sure that they've got the capacity in order to respond to those. And the third thing is that they make sure that where community-led organisations support older people, that they receive funding for that, so they don't become overwhelmed and are unable to respond to the community need. And the reason why that project, I think, is so successful and based on such an integrated and person-centered model is because the organisation itself is based on the needs of older people. And it was set up in 2011. And over the last 12 years, it's connected or developed a series of older people's groups in the locality. And I think currently it's engaging with 50 older people's groups on a regular basis. And older people involved throughout the whole organisation. So they're involved on the board, they're involved in the development of projects, they're involved in the evaluation activities, and they're involved in the delivery as well. And that means the organisation has evolved in response to what's important to older people. So along with this social prescribing project, it also has a whole range of other activities, which include a befriending service, which include activity groups, which includes mentoring and support for people. So that's because it's based with older people, involves older people, it can therefore respond to the needs that older people think are important. And the final reason I think it's really important, it's a great example, because of the credibility that MIAP has with older people, and because the credibility has with these different professional groups, it can bring them together for meaningful discussions. And at the start and the end of our demonstrator project, we had one of the best world cafes, or two of the best world cafes I've ever been part of, where we had older people, we had professionals, we had policymakers come together to talk about the importance of asset-based working and to look for opportunities to make it better in Mid and East Antrim and Northern Ireland as a whole.
Thank you so much, Robin, for that. There was so much in what you said, and a key nugget that stood out for me when you kicked off your example is you talked about the importance of the lived experience knowledge and wisdom, as well as the practice-based wisdom in trying to move any dial, in our system, and also providing a lot of power to the community, I heard, and really learning from individuals themselves what is it that they need, and creating spaces for people to dialogue and to build together. So I saw a clear example of integration with the health and social services, community power, and also harnessing the knowledge of so many people. But Helen, I'm going to look over to you now to answer a similar question, is how do you see these things coming together, being integrated care and engagement? And can you provide an example based on the work that you're doing?
Yeah, so just for a little context around the work that we've been doing with rural Alberta communities, is that we've brought together folks from the health sector, so doctors' offices, home care, those kind of folks, as well as social services, and then some community partners too. So people like maybe from the libraries, from the churches, community organizations, as well as our work focused on people living with dementia. So folks living with dementia and their carers, and brought them together in what we're calling collaboratives to look at what exists within their community to support well-being. And that's been really key for us to move away from a medical kind of model approach to it, but to be asking questions about well-being and what supports theirs. And we're looking at supporting those individuals, but also that team that's coming together also. So what's the collective well-being? What is needed there for them to be able to sustain their work? And the key role for the individuals, so people living with dementia and carers, has been that they have really set the priorities within this work. Some of that was done through research that we did, but also on every time those collaboratives meet. And we worked with 5 rural communities in the last 3 years around that. And so they're setting the priorities. They're involved as much as they're able to be in terms of, implementing activities and that kind of thing with it. And I think part of what's come out of that is a really great understanding of what is important to those folks. I heard what you were saying before, Carrie, in terms of relationships are seen as taking a long time, and absolutely it takes time to build those. But what we found is that once the relationships are built, then the work just goes crazy, and it's very creative, and it produces way more than we ever expected. We were hoping, our initiative started during the pandemic, and we were hoping for one activity per community would get implemented, and it turned out to be 60 activities overall across those 5 communities, and that included things like arts programs, exercise programs, education events, a lot of support programs, memory cafes, those kinds of things. So it's incredible what can happen when people come together. I think the other kind of unique thing that we've been learning about within there, and it's one of the big things within the healthcare system, is around navigation. And what we really heard from these teams was that there's kind of a hub and spoke model that they're using. There's a core group of people, and then they have connections within their community. And anytime an individual touches any one of those communities in the hub and a person within the hub and spoke, then that person becomes responsible for that navigation through the system to where that person needs to really get lined up. And I think, it's relationship based, and I think it's really powerful, and I think it's really key for this work to move forward with it.
Thank you so much, Helen. And it's so wonderful, to hear, just how much impact you can have by taking the time to build those relationships. Because we often hear you have to go slow to go fast. And you ended up creating such big impact after creating those connections, engaging with people who have dementia, their families, other members of the community, and also focusing on local assets. And I heard that from Robin as well, like what's currently working well that can be leveraged. We don't always have to create new. So I love that asset-based approach and really looking to the community for the answers. So thank you for that. We're going to switch gears a bit, and I'm looking over at you, Sandra, and I know you're someone who you've been involved in the health system as a patient for many years. You've been involved in the health system in terms of co-design and building things with various types of individuals, be it providers, researchers, managers in the health system. I just want to go back to what does integrated care even mean? From your perspective, you're someone who's been involved in different ways in the health system. How do you define integrated care? And the follow-up I'll ask you after is, why bother engaging with patients, families, and caregivers in integrated care? So we'll start with the integrated care one. What does it mean to you?
Thanks, Carrie. Also, I wanted to acknowledge that although I work with a lot of groups, I'm here today representing the Patient Advisors Network, a national organization of patient advisors. And what does integrated care mean to me? Well, if I was to give a definition, I would say coordinated, effective, and efficient care with empathy and compassion that reflects a holistic approach to a person's health needs from prevention to end of life, focusing on physical, mental, and social health. So myself, as a patient with multiple morbidities and an active user of our healthcare system for the majority of my life, integrated care is necessary. My safety, treatment options, and outcomes rely on integrated care. I still today need to repeat my history each time I see a new care provider, have had delays in receiving diagnosis. For example, it took 10 years for me to find out I had a liver disease and Crohn's. And many times I was told that it was in my head or it was my diet, which gaslighting is another thing that happens to patients, unfortunately. I've been required to duplicate tests, which is a cost of our system. And I've had issues with errors with medications because of lack of integrated care. I also need to use multiple patient portals to access my health records, and in some cases are required to pay for them. I hope that someday I could have a case manager or navigator to help manage my care. I feel that I've gained a master's in navigating our healthcare system. And to be honest with you, looking after my healthcare is a full-time job. So one of the things that I wanted to point out, first of all, of course, we want to have patients and caregivers and community involved, but I also want to acknowledge that engagement around primary care and health sectors has been a challenge. And so how is it like, because of the way our system is fragmented, everyone sort of does their little part of the job. They see one part of the system and they don't see everything. So I want to acknowledge that. But I also want to go back now and refer to the slide that showed the different degrees of engagement and powers. The first item should move, in my opinion, from inform to empower. So when we're talking about our communications with primary care, so we're in the doctor's office, we have gone from an inform, but we need to go to an empowered. We need to work towards changing the provider-patient differential by having providers see their patients as partners through their patients as partners through shared decision making. Patients need to feel empowered to be active participants in their healthcare plan and to express what matters most to them. And also, too, patients should be acknowledged for the knowledge that they have gained by their lived experience. Of course, our doctors have a lot of knowledge, but living with an illness and navigating the healthcare system as a whole, as I said before, you get a master's in that. Going to the next section, which was engaging patients and their family. This type of engagement gives the opportunity for providers to receive feedback directly from a diverse group of patients and caregivers on their experience and suggestions to help with improving patient experience and process it. It's a great way to help evaluate performance. And then the last part on codifying and co-design. Co-design is something that, to me, is where the magic happens, where providers, patient, caregivers, and community collaborate to define and co-design the best healthcare system. We need to find another word for this, meaning the healthcare system. I don't like calling it a system. Maybe that's the problem. That advances meaningful change. Thank you. And I will pass it over to Walter. Thank you, Walter.
Thanks very much. And hopefully we'll have Carrie back here soon to help guide us. But in the meantime, I want to have the opportunity to bring Nikia into this conversation. And Nikia, you've done a lot of work in the space of health equity. And we're really interested in knowing, if you have some thoughts around how we can better consider or best consider equity, diversity, and inclusion in our efforts to engage the patient's family for integrated care.
Thanks, Walter. That's a great question. So whenever I think about a question like that, I first kind of stop and say to myself, and say to myself / the folks that I'm chatting with, is essentially, how are you defining equity, right? Because equity in North America is going to look different than equity in, for example, Ireland, in, the Caribbean, and so on and so forth. So how we're defining equity in the context of where we work is beyond importance to start that journey to better engage for integrated care. Same thing with diversity, same thing with inclusion. Those are going to look different in different contexts. And when we're having that conversation, oftentimes what can happen is, because equity, diversity, inclusion has gained momentum and interest and focus in recent years, is it comes into play, those conversations are had, but then the work is done without actually stopping and critically reflecting on what those things mean. So as I said, we should first start off with what are those definitions look like in the context and the spaces that we're working in? And then how are we actually moving towards incorporating that into integrated care? Because again, traditionally, kind of similar to the slide that Carrie mentioned, the usual kind of way of doing things is, you find a problem, whether it be through data that's being collected within your institution, organization, you identify that as something that needs to be addressed, and then you potentially move towards the literature, look for solutions there. And then maybe after doing all those things, then you say, oh, you know what, it's time for us to engage with community patients and caregivers here. And I'm sure I'm preaching to the choir culture here, but that's not the way that we should be doing things, right? So what we should be doing is we should be actively engaging and having conversations with caregivers, patients, and community members from the very beginning. We don't wait until we're at the end of things and we found problems to then say, oh, this is a time when we should be chatting with folks to see how they can help us. We work for patients, we work for community, we work for caregivers. It's not the other way around. And when we start from a place of, you know, being the holders of knowledge rather than individuals that are looking to gain better understandings as to how to support and enhance the health and well-being of others, then we essentially are working from a point of disadvantage for the folks that we're supposed to be supporting. So starting the journey, working with patients, working with caregivers and communities is where we should, you know, begin our journeys together. And in doing so, that would lead, you know, in an ideal world, I say that, you know, again, preaching the choir here, in an ideal world, you know, that's where we should be starting. And once we do that, then we can actually then say, you know, we have some ideas of what diversity, equity, inclusion are, but what are your thoughts on those ideas? And then how can we work together to be better with co-design? How can we work better to make sure that what we're thinking of doing aligns with what is actually happening in the context of how you are, you know, navigating the system? As Sandra said, she's probably got not a master's, but she's got a PhD, I'm sure, in, you know, healthcare right now. And you shouldn't have to do that. You shouldn't have to be actively involved in that way, in that depth, to take care of yourself. That should be something that's taken off the plate so that you can actually, you know, be better health-wise, and your health outcomes can be involved and enhanced. So how do we make sure that we're taking those things off the plates of folks? And how do we make sure that we streamline care in a way that responds to patients, caregivers, and communities' needs, that is actually, you know, equitable, that actually reflects a diversity of needs and places and spaces that people are coming from? And how do we make sure that we can be as inclusive as possible so that folks get the needs that they have, you know, addressed and cared for when they need it the most?